Okay, we got expected a few more of our members to be with us, and obviously they're running late. But we want to start on time. We respect everyone's time. We've got a great presentation today. Want to kind of pick up where we met last month. I want to recognize Dr. Lampton, who's with us today. He was on Zoom last meeting, and I would like to introduce two new members. Aaron Sisk is on Zoom. Aaron, would you please tell us a little bit about yourself?
Certainly, Mr. Chairman. Thank you, and really excited to be a part of this. Sorry I couldn't be there today. I had some business obligations that were planned before I knew I was on this committee. So I am the President and CEO of Magnolia Health, which is the Centene subsidiary in Mississippi. I have been with Centene for 12 years, all in Mississippi, all at Magnolia Health. Prior to that, I worked 7 years at the Mississippi Insurance Department. I got to know a lot of you guys during that time and during my stint with Centene. Native Mississippian, lived in Madison County my entire life. And so just really happy to be a part of this important effort.
Thank you so much. We appreciate you being with us today. And we have one other committee member who's new to the meeting today, Dr. Jay Underwood. Dr. Underwood, would you tell us a little bit about yourself, please?
Good morning, Mr. Chairman. Thank you for allowing me to be here and facilitating this effort. As he said, I'm Jay Underwood. I'm originally from here. I'm a physician with GI Associates here. Been with the group since 2001, I guess, and am part of an organization called Mississippi Independent Physician Practices Association, which we're proud to represent 400 plus independent physicians around the providers around the state, and obviously have a vested interest in advancing the well-being of all the great people of this state, our patients. Again, just really appreciate the opportunity to put our heads together with all of the folks with whom we share common interests here today. And thanks for allowing me to be here.
We appreciate your time and commitment. Thank you so much. I'd like to mention a couple of things that have occurred since our last meeting and on a subject that we discussed here. You might recall we had a pharmacist from Novo Nordisk talk about anti-obesity medication, and he mentioned at the time that there was a study they were doing on fatty livers and fatty liver disease, and that study was released the week after we were here, and it was very positive news. At least I know the stock market appreciated it. It went up 5% in one day, so that was very positive news on their study. And also, just a few days after that, Eli Lilly made advancements on a pill form of anti-obesity medication. That's great news to hear. So that's a subject that I know is important to us, and I think something we're going to be hearing more and more about. Today, we want to start with telehealth legislation. We passed telehealth legislation about 4 years ago, and we've got a great presentation, going to be very interesting, from University Medical Center. I want to tell you a little bit about some positive reinforcement that I've had since the bill has passed. I've had one constituent tell me of a situation where telehealth saved her a whole lot of time and effort. She suffered from migraine headaches and was given a very effective monthly injection, but the doctor said, I need to see you back in 6 months for a follow-up to make sure there's no adverse reactions. And she was able to do that 6-month follow-up visit by telehealth with her cell phone, and it took 6 minutes to get that prescription reenacted. Do you think about the positives of a patient not clogging up a medical office and the doctor being able to probably see more patients in that day by doing that? So that's very positive. Then I had another constituent tell me about a rash that he had. And I don't know if you've tried to call a dermatologist lately, but sometimes you call them and you say, I've got a rash and I'm really itching. They say, we can see you in 6 weeks because they're in such demand. I mean, that just doesn't work. But this fellow was able to send we've got great quality cameras on these phones, and send a picture of the rash. And it was a condition that the dermatologist recognized that had been with the patient before, and the patient had the right medication and was able to prescribe that medication. And it's done through the portal of the doctor's office. So this is two real positive situations that I've positively heard of. And of course, Mississippi is such a rural state. We have areas that don't have access to certain medical providers, and that's kind of the gist of what we have today. We're going to have a presentation from University Medical Center on the advancements that they have done with their telemedicine department. And I'd like to ask Christy Sims with University Medical Center to please come forward, and she's going to introduce our presentation from University Medical Center.
Good morning, and thank you so much, Chairman Michelle, Chairman Creekmore, for the invitation for the University of Mississippi Medical Center, Center for Telehealth and Emerging Technologies to present today. We have a great team here, and they're the experts, so I'm going to introduce them briefly and then get out of the way and turn it over to them. First, we have Dr. Saurabh Chandra. He is our Chief Telehealth Officer. He's a critical care physician by training and has been at the helm of the Center for Telehealth for 5 years. He is the shortest termer of the people who are here. Everyone else has been at telehealth even longer than 5 years. We've got a very seasoned and experienced team. Beside him is Dr. Tiersany Davis. She is Director of Clinical Programs and Strategy, and she is a nurse practitioner by training. Greg Hall is the Director of IT, very critical when you're talking about telemedicine, and probably the first or second person ever hired at the Center for Telehealth almost 20 years ago. And beside him, Kyle Brewer, who is the department administrator. He keeps all the trains on the track. And behind him, right there, is Curtis Anders. He is our Chief of Managed Care. So he deals with all the payers and knows a lot about insurance and telehealth and how the two intersect. So with that, I will turn it over to them, and thank you again for the opportunity.
Thank you, Christy, for the introduction. Thank you, Mr. Chairman, for the kind introduction about the benefits of telehealth, for the invitation today for our team and myself to present about telehealth and what we do here at the Center for Telehealth, the adoption and utilization of our program in the state, and some of the barriers and challenges that we are facing. Do I have the presentation? While we are waiting for the presentation to be up, there it is. So this slide just shows an overview of UMMC. I think everybody is familiar about UMMC, the only academic medical center in the state's hub for education, research, and advanced clinical care. It is the second largest employer in the state. It has more than 1,000 beds available for patient care. The next slide. Actually, there we go. So the next slide shows some of the important milestones in our journey here at the Center for Telehealth. And one thing that I'm really proud of is that most of the country understood the benefits and started talking about telehealth after the pandemic. Mississippi is one of the few states in the country that recognize the benefits of telehealth for the rural and underserved population, and actually invested in telehealth long time back when people didn't even understand what telehealth stood for. And we started programs way back in the early 2000s by setting up a robust telehealth network, tele-emergency network that provides consultations from our emergency department physicians to other providers at more than 20 critical access hospitals. And some of the important milestones that we have achieved is a designation as one of the 2 centers of excellence in the country by HRSA in 2017. And we were successful in our redesignation in 2021. And we are working on our next redesignation application in 2026. Before I take a deeper dive and talk about some of our programs, it is important for me to make everyone aware of what is covered under the umbrella of telemedicine and telehealth. As everybody understands, telehealth is all about taking care of patients when the provider and the patients are not located at the same place. But within the telehealth, there are different modalities that allow us to take care of patients remotely. And I think everybody is more familiar with the audio video modality of telehealth, where you can talk to the patient, you can interact with the patient, but you also use the video to get more clinical information and for us to be able to see the patients remotely. But there are other modalities there as well. One is store and forward. And the store and forward is passing on, and I think Mr. Chairman mentioned, taking pictures of a rash and sending it to the provider. That is store and forward. And within the store and forward, there is one new modality that has recently come into a lot of focus, and that is called provider-to-provider consultation. And I'm going to talk a little bit about the importance of that for our state. But just to define what provider-to-provider, or sometimes called e-consult, stands for, it allows primary care physicians to send patient information, summarize a note, and send it electronically to a specialist to get their recommendation. Now, this is not a direct interaction from the specialist with the patient, but it allows the specialist to actually see the pertinent patient information and give their recommendation. And how does it benefit the patient? In our state, there are many, there is a lack of specialists, and this allows patients not to travel unnecessarily long distances to go and visit the specialist, and mainly for like follow-up visits. Sometimes the patient is coming and seeing an endocrinologist or a cardiologist for a 10-minute visit, and they're driving 2 hours for their appointment. So this is a modality that is gaining a lot of traction for allowing patients to get recommendations from the specialist. Another modality that we are very proud of, because we built a lot of signature programs around this, is the remote patient monitoring program, which allows us to give devices to patients at home and allows us to capture their biometric data like blood pressure, glucose, and other biometric data, and allows that to flow directly to our team at the Center for Telehealth, where our providers can make recommendations. And we have really achieved some tremendous results, and I'm going to talk about that in a minute. So those are some of the modalities that come under the umbrella of telehealth. As I mentioned, that we are one of the 2 centers of excellence recognized by HRSA, and we are very proud of the work that we do here. We have, it allows us to innovate, allows us to come up with new technologies, new ways of using and utilizing telehealth, capturing data, coming up with the best evidence-based best practices, then sets the paradigm to be replicated around the nation. I'm very proud of our national presence as well. I'm sorry, I lost the presentation, but the slide was showing our national presence around the country, and we are working with entities in multiple states, working with them and collaborating them to actually implement, study, and come up with evidence-based practices that can be replicated throughout the country. This is our utilization. You see the utilization peaked during 2020, and this is UMMC's number of live audio-video visits that have trickled down a little bit, but still staying at a level that is providing valuable service to the population in the entire state. And this is our footprint around the state. We are in some form of other. We have a presence in 61 counties at more than 180 sites. But if you look into our urgent care and direct-to-consumer program, which allows us to provide urgent care services, behavioral services, we provide access to the entire population in the state. They can join and they can a live audio visit from their mobile devices from anywhere in the state and can benefit from getting consultations from our urgent care as well as behavioral health team. The next slide just shows, as I mentioned about the teleemergency program, just shows the locations that they are present. And now I'm going to invite Dr. Tierney Davis. She's our Director of Clinical Strategy and Program and has the oversight on the behavioral health program and the maternal health program. She's going to talk about our footprint in the schools, in IHL public universities, and also talk a little bit about the maternal health program. And as we all know, recently data came out that our infant mortality rates are worsening. And this maternal health program is one of the ways that we can improve on our rates in the entire state. So, beautiful.
Good morning. As Dr. Chandra said, I'm going to talk about some of our programs that I feel like are really making an impact on the people of Mississippi. I'm from Durant, Mississippi, very small town, some of you may be familiar with. And I just tell you, if these things existed back then, how much of a benefit it would have been to those people living in the rural areas. So the Mississippi School-Based Telehealth Program, we started school-based telehealth, or we attempted to start school-based telehealth back in 2013. But at that time, the difficulty was that schools were not a recognized site of service for telehealth for Medicaid billing. And we know that many of our young people at K through 12 schools do have Medicaid. So that was an issue that we had then, but we were able to pilot some things with some external resources. And it proved out that school telehealth could happen and it could benefit the students in rural Mississippi and the K through 12 schools. Most recently, we were awarded some funding from MDE that allowed us to do one of the largest, if not the largest, school-based telehealth program in the nation that we know of. And at that time, we were in 73 school districts across the state. We did offer it to all, but those were the ones that chose to do it. Right now, we are in a different iteration of that same program, and we are testing out sustainability for this program. So today we are in 32 school districts across the state, serving 205 schools. We have access to almost 80,000 students. We've had over 6,000 telehealth encounters since inception, and over 3,000 unique students treated since this inception. And as Dr. Chandra mentioned, this is urgent care provided at the school and also behavioral health, which includes licensed professional counselors, licensed clinical social workers, and psychiatric nurse practitioners. I will say the behavioral health one is a hit in the schools. Both the parents, the students, and the faculty and staff have reported that having access to those counselors and those providers who can keep the students that are on their medications has been instrumental for them. Now I'll talk about one. This one is really dear to my heart. I don't have any children, but I have a heart for mothers, especially those who are living in the rural areas. This is our remote patient monitoring program for maternity. So right now, let me just give you a little background on it. So we started it in Northeast Mississippi, working with one of the federally qualified health centers. And we thought that since that health center did not have maternity services, that we would get a lot of referrals into this program. The goal is not only to address those moms who are high risk and identified high risk, but to stop moms from becoming high risk, or to recognize that high risk tendency very early and to get them to care early. So we used our remote patient monitoring platform that we already had for chronic disease management, and we tailored it to maternity. So what these moms get is they get access to, or I call them a partner in pregnancy. We have a registered nurse who is a mother-baby nurse who follows these mothers throughout their entire pregnancy and up to 12 months after they deliver the baby. And what she has been able to do is to identify opportunities for advocacy. You know, we've had some times when a mom has called to see the MFM and they were scheduled out several weeks, but we knew that the issue was something that needed to be addressed sooner. And Tiffany was able to talk to that MFM or their representative and plead that mom's case to get them in. We all know that there are many hospitals in Mississippi who have decided not to have OB services anymore. So it's very important for those moms to have someone or some type of bridge to carry them through their pregnancy. This slide just shows a little bit of the impact. We've had 117 mothers enrolled. Right now, if all of the moms who are currently on the program stay on and finish this, and this is an actual study, let me say that. This is an actual study, and they finish the study, that will be 130 mothers in Mississippi who have finished the study. So far, we've had 61 babies born, and 59 moms are currently active on the program. This is what they get. They get the mom, they also, the nurse, the mother baby nurse. They also get virtual visits that they can have through those tablets. So for moms that don't have data plans and don't have the smartphones, if they have this kit, they have that. So they have access to our urgent care program and also to the behavioral health team at home. We do multiple screenings. I won't list all of those, but one of the most important ones is they get mental health screenings several times at various intervals throughout their pregnancy. And we know that postpartum depression is a big issue, but moms also have depression during their pregnancy. And so we can catch that sooner. We are identifying social determinants of health that may affect, their pregnancy, their delivery, and of course, their ability to mother their babies throughout and connecting them to the appropriate resources. Next slide. Oh, I got the slide thing. Okay. All right. So one of the latest things that we have done at UMMC was to establish the Unite Clinic. This was previously under the Department of Psychiatry at UMMC, but we have now taken it under our body of work at the Center for Telehealth and Emerging Technologies. And so this provides behavioral health services to all of the students that attend the IHL universities, and it is free of charge to those students. So they can go onto the website and self-schedule themselves. They can choose counseling or medication management, and they will see either a licensed professional counselor or our psychiatric mental health nurse practitioner. And this was the utilization, this is prior to the Center for Telehealth taking it under our wings, but it shows you that it is a great need. There is a great need. And these are students who either are self-referring or they're being referred by their on-site counseling centers at the schools. And we've received lots of positive feedback from those counseling centers as well. So I won't read the numbers to you, but you see that it is impactful. And I'll pass this back over to Dr. Chandra.
Thank you. I know that I'm coming up on time, so I'm going to quickly go through some of these slides because there's a lot to unpack. This is the slide that shows the chronic disease burden in our state. We have almost 14% of the population that's suffering from diabetes, 40% that are obese, around 40% that has blood pressure, and we have one of the worst infant mortality rates in the country as well. And we want to focus, I want to bring to your attention about the results that we have achieved from our remote patient monitoring program for some of these chronic diseases like diabetes, hypertension, and congestive heart failure. Actually, there's data that shows that if you have to improve on one health outcome to have the biggest impact on your overall health, that would be bringing your blood pressures within normal parameters. And what we have at our center achieved tremendous results in improving diabetic outcomes, improving the scores on hemoglobin A1Cs, improving blood pressure readings for the patients, and more importantly, for congestive heart failure, we can prevent, recent data shows that we can have reduction in unnecessary hospitalizations for patients suffering from congestive heart failure. So I think everyone in the audience have heard about workforce shortage, especially healthcare workforce shortage. especially nursing shortage, not only in the state, but around the country, and how that was exacerbated during the pandemic. So I'm just going to talk about one of our programs that we implemented to mitigate and improve on the workforce shortage in the state, and that by creating better environment for the nurses. So we implemented a virtual nursing program where virtual nurses offload the bedside nurses and take on some of their responsibilities like admissions, discharges, rounding on the patients, and it has achieved tremendous results. And what I'm going to show you is in the first 18 months of the program, there was zero turnover in the unit where we implemented our virtual nursing program. Not only that, we in that unit, when we did our employee engagement survey, we had one of the best employee engagement scores in the entire UMMC. Very proud of that. So we have gone to the next level, and what we are showing in this slide is like we have our virtual nursing program, and we are trying to bring new technologies like artificial intelligence. And I know Dr. Jennifer Bryan is in the audience, and she and our team have engaged and talked about AI, and she's a big proponent of that. And what I want to show here is that how we can enhance virtual nursing by integrating with AI technologies. And what we are showing here is the AI is focusing on fall prevention. When the patient, high-risk patients, they are getting up and they are, it can alert our virtual nurses who can then intervene. And our initial data has shown that 67% reduction in falls with harms in one of the units that we just implemented this program. So we are looking into the future, trying to bring innovative new technologies like artificial intelligence to enhance the value and outcome for some of our programs. Again, I talked about rural hospitals and how we can help rural hospitals, help them with the financial viability, but also bringing in specialist services directly there. And I talked about workforce shortage, and some of the times rural hospitals are facing difficulties in recruiting physicians. Case in point, there is South Central Regional Medical Center lost one of their neurologists. They turned to us, and now we have developed a great program, a hybrid program, where for 15 days, the neurologist at the bedside is providing services, and 15 days, those services are covered by our teleneurologists. We have a telecritical care program in 3 hospitals, Copiah County Medical Center, McGee General Hospital, and Greenwood Lafleur Hospital as well, that has benefited these hospitals from sending patients to other higher level of care, allowing the patients to receive care from specialists in their communities, allowing the hospitals to keep the patients in their communities. This is a study that we just finished and published in a very reputable journal, and that shows there's a lot of ongoing debate about the outcomes and the cost of providing telehealth services. So we looked at our Medicare data from 2019 to 2021 and asked the question, is the telehealth, when we talk about cost and we talk about higher costs, is it just because telehealth is actually responsible for the higher cost, or is it because some of the patients have unmet needs? And so it is not the cost that is due to the telehealth services, but it could be because these patients are having unmet needs, are more sicker than are using telehealth. So we then asked the question, what if we do a study and compare apples to apples and compare patients who utilized telehealth, who did not utilize telehealth, but they were comparable in their demographics, in their chronic disease burden. And so we did that study, and we actually have fantastic results that was published. We also had the opportunity to present together with the Congressional Budget Office a few months ago. And what it shows is that although there may be a little bit increased outpatient visits and ED visits, but overall decrease in the hospitalization, decrease in overall spending, whether it is in the medical or outpatient setting. So I'm going to wrap up my presentation, and then we'll actually move to show some the actual demo of how we implement these telehealth visits. But I wanted to talk about some of the challenges and barriers to a wider adoption of telehealth in the state. And the first thing that I'm going to talk about is payment parity or lack of payment parity. And when we talk about parities, there are two types of parities that I want to bring everyone's attention to. One is coverage parity, that you cover for those services, and the other is the payment parity, when those services that are covered are paid for. I think in our Mississippi code provides payment parity for store and forward telemedicine services. There's no payment parity for any other type of telemedicine, and lack of reimbursement for telehealth audio-video visits limits access to providers for patients in rural hospitals. So we want to recommend to the committee here that they should ensure payment parity for specific services like behavioral health that would allow us to provide, have wider adoption for our services and provide these services to patients throughout the state. Continuing, the next challenge too is, number two is the restrictions on remote patient monitoring. So what we have seen is that Medicaid requires a lengthy process for prior authorization that delays the time that the referral is made to us to the time that we can offer these services to those patients. And many times the process falls somewhere in between, preventing us to provide these services to wider population in the state. And so we wanted to recommend to waive prior authorization and make this process more seamless, easier, so that we can onboard these patients faster and the process is more streamlined. And this service is available for more diseases that are currently allowed. For example, as we mentioned, we talked about our maternal health program. The pregnant moms are not offered these services unless they have a chronic disease. And if we really want to make an impact on infant mortality on our state, then we should be looking into allowing some of our remote patient monitoring to be available for pregnant moms, even without chronic diseases. I talked about the provider-to-provider consults at the start of my presentation. And one of the barriers that we are facing in our provider-to-provider space is that there's no clarity in the definition, and it's not including in one of the covered services in our statute. And I think so that results in lack of access to specialists and delays their care. And so we are recommending that e-consults or provider-to-provider consults are defined explicitly in our state law and Medicaid policy that will ensure coverage and payment parity for provider-to-provider consults and will allow us to expand access throughout the state. One of the last challenges that I wanted to talk about is regarding video-only mandate. In our statute, it requires telemedicine to be real-time audio-visual capable. Exception is RPM and store forward. Commissioner of Insurance may adopt rules surrounding utilization of telehealth just for audio visits only. So what we recommend is to amend the coverage and payment parity statute to cover audio-only telehealth for defined conditions, like for behavioral health, for follow-ups, because many of the patients who are living in our state in rural areas may not have access to broadband, internet or cellular broadband connectivity, and they may not be able to access telehealth through our audio-visual platform. And some of those guardrails can be put in place, but we want to recommend that for patients who are not, digitally savvy, and who don't have good broadband access, maybe they can use audio-only visits in place of audio video. So I'm going to stop here because we are running out of time, and allowed my director of IT to actually show the demo, but I'm also glad to take any questions and on behalf of the audience. Thank you.
I had more of just a comment than a question, a couple of things that he said that were impactful just in my practice as a family doctor. One is, I would just like to point out that pregnancy in and of itself is a high-risk condition, and sometimes we skip through that. And so I was really glad to see that you bring up the point that I think it's important that we recognize that requiring a chronic condition is probably a step too far at that point. It's already high risk. The payment parity piece is something that we've been advocating at the association now for about 5 years, really since COVID. We're providing those services, and I'm excited to see the demo because the care is quite complex. It's much more than FaceTime many times, and a lot can be done. And then agree, again, the audio video thing is a hang up, and appreciate that. Are you seeing that as more of a concern in rural and maybe elderly populations who need care?
Absolutely.
And
And thank you for your support, Dr. Brian, but we are seeing many patients who are, living in rural areas. They may not be having access to broadband. And we did a study, one of our pediatric surgeons, Dr. Morris, did a study where after post-op care, he compared patients who came for an in-person visit with follow-up that happened through audio-only visit, and he showed comparable results. And think about it, in his study, he showed that parents sometimes had to bring, on average, they had to travel 100 miles to bring their kids for a 10 or 15-minute follow-up. And that could just be avoided by just having these audio visits for patients who did not have access to broadband. Yeah, so if there are no more questions, we are happy to actually do a demonstration of how we connect using our laptop with some rural hospitals. In this case, we are going to be connecting to Magee General Hospital. And Greg, do you want to go ahead?
So good morning. I do want to state I've been with UMC for 25 years. I did start this program, started the video connections back in 2002 and 2003 when we started teleemergency. Just talk a little bit of how far the technology has come. I would not have been able to do this demo as we're sitting here 20 years ago. You would have had to come down to UMC to be able to to get into the video connection. So just realize that we've gotten to the point where we really can give the physicians the ability to do care from anywhere, and how forward the technology has really come in that realm. But right now I'm going to connect to Magee General. So as you know, it's about 40 miles south of Jackson. We have a couple of connections with them. We have a connection for emergency medicine, and then we have a connection for telecritical care. I'm connecting to Jill Nicholas. She's a family and acute nurse practitioner that works in Magee. And just to give you an idea of what it looks like. Jill, hopefully you can hear me.
I can hear you. Can you hear us?
We can. So Jill, if you'll just give us a bit overview of what we're doing down in Magee and just what the community impact is for Magee.
Sure. So with the assistance of university, we are able to bring a higher care to our patients in this rural. We're able to prevent transfers, provide high level care, and really just help support the hospital. I'm sorry, the echoes got me a little.
Yeah, we have a lot of microphones in this room, so apologize about some of the video audio feedback we're getting,
Yeah.
but
we've
really,
seen a huge impact already.
so I'm just going to show you some of the capability of the camera. So we do have full control of the camera on Jill's end. So I can pan it left, I can pan it right. So we do have a patient in the room and a couple other people. So I'll be able to zoom in on the patient. The people on the other end always hate this part when I zoom in, but it is part of the exam that we can do is we can get very close in and actually be able to see the bedside pillow in this instance. So great capability on the cameras. You can tell we can have a regular conversation back and forth. Nobody's screaming, nobody's yelling. It really is great technology. So thank you, Jill. Unless anybody has any questions for her, I want to hang up with McGee. Thanks, Jill.
Thanks.
Just to show you another part, this was a little bit harder to show just simply because I can't get my cell phone to connect to the Zoom call. I have a text message waiting for me. This is the scenario where I'm at home. I have my typical upper respiratory infection that I know is going to happen every 6 months because I live in the great state of Mississippi and I have a grass allergy. So those two things don't mix together very well. So I'm going to click on the link. You see, I'm not doing anything special on my phone. I just literally clicked on the link. Don't have to have any software or anything else on my phone. It's going to ask me for permission to click on my microphone and camera. And I am now connected to Christy Goodson, who is one of our nurse practitioners that works for our urgent care program. So Christy, I know you're not seeing me at the moment, but so she said she actually is. So Christy's working our urgent care program as we speak. So when people need a urgent care visit, instead of going to a local community provider, they can get onto our UMMCDU platform and do a telehealth visit that way. Anybody want to talk to Christy? Because I'll be more than happy to pass my phone around. Yeah, yes, sir. The typical workflow is that they would go through our patient portal. And at that point, they would go into the UMMCDU waiting queue. Part of that process is a typical intake form, just like you would at the clinic. So part of the questions around hospital, insurance and coverage. So they put in their coverage just like they would if they were at the clinic. We do a verification on the back end before they get into the video call. They'll let the consumer know how much this call is going to cost them if they have a copay. And at that point, it'll ask them for that payment. Yes, sir. Thank you, Christy.
I just wanted to add in too that as we've watched this evolve over the years, of course, this is UMC and the community physicians are glad they're there. There's a lot of patients to go around, a lot of patients that need to be seen. There's urgent cares in urban areas on every corner. And with a model of business, we know in our practices, we need to meet the patients where they are too. So many community physicians are also, like I provide very similar service through very similar software in my clinic. It doesn't threaten me that they do it because I should be taking care of my patients. It's about getting access to the patients. So, I applaud this type of technology and access around the state because many things can be done, complex things by telemedicine. And we didn't look at the level here, but there are many doctors and others providing the level of looking at your eardrum and listening to your heart sounds via similar technology. It's really amazing the access we can get through this.
Yeah, the great thing about that technology is we literally can hook up any scope that you would use in your everyday practice. We can hook up stethoscopes, otoscopes, ENT, any of the Stryker type surgery scopes. Everything can be connected to these camera systems now.
Anybody else have a comment or question? Okay, Representative Creekmore.
Is closed caption an option for, especially for elderly, may not can hear as well?
Yes, sir, it is. And as AI takes up more and more, we're able to actually translate in real time now too. We're starting to do studies around translation in real time. So if you don't have a native Spanish speaker that can provide telehealth services, that translation can happen real time. That is in the infancy stage. We're not at the point where it's in production yet, but that is coming as well.
And is it recorded on the patient's end so that the family could go back and watch? Or
We do not record.
Okay, all right, thank you.
I had a family member at UMC recently and had the AI nursing, which I think is awesome. But I did have a question I genuinely don't know the answer to, which is consent on that. Like I have a really private family member too. This one didn't care but explain that process about the camera in the room and what conversations are had.
Yeah, so as you're coming into UMC now, even if you're not in a room that is camera equipped, we do obtain consent to, for those type of rooms, just in case you happen to be in one. But if you do go into one of the rooms with the camera, before the camera's ever turned on, the nurse comes in, it explains the system to the patient, gets the understanding to make sure that the family and the patient understands what the camera is for. And at that time, they're able to say, no, I don't want to be in this type of room. And at that point, we take them out of one of the camera equipped rooms. So the patient definitely has the ability to not consent to be in these type of rooms.
We want to thank you so much for the great presentation on a wonderful service that y'all offer to Mississippi. And thank you for y'all time today, for being with us. We really appreciate it. I want to remind the members of the committee that we have, each of you has a suggested form for future topics. If while we're meeting today, you can think of something else you'd like us to bring up at the next meeting or the following meeting. We have reached out to anybody. One subject we have today is going to come as a result of something that was mentioned in our last meeting. And also, I'm not talking about just committee members, but anyone in the audience, if you have a subject you'd like discussed. I've had a few of you approach me on some issues, and we don't want to turn any opportunity down, and would like to cover any subject that's of interest. So we're pleased now to have representatives from the Mississippi Hospital Association. I want to ask please to come forward, Richard Roberson, Mississippi Hospital Association President and CEO, and Leah Rupp-Smith, Mississippi Hospital Association General Counsel, Vice President for Advocacy and Policy. Their subject today is on Medicare Advantage, artificial intelligence, and other issues impacting patients and hospitals. And Richard, thank you so much for being with us today.
Thank you, Mr. Chairman and members of the committee. It's a pleasure to present to you today and talk about some really important things going on in the world of insurance and healthcare. And I want to start just in remembrance of today being September 11th, and our thoughts and prayers continue to go out to those families that were affected 24 years ago, which is hard to believe it's been that long. But I think there were 469 first responders that perished on 9/11. So our thoughts in particular as part of our healthcare community and what we do and those that we serve, we want to think about them today too. So thank you for that indulgence. Let's see here. Slide. Is this what we're doing on the? Yep. So just a little bit of background regarding MHA and why we do what we do. The object of our association is essentially to promote the welfare of the patients that we serve in our communities and to support our members in providing efficient and economic care in the things that we go about doing to serve our communities. And y'all have heard me say it a million times, but I think it's worth continuing to repeat. Our hospitals across the state of Mississippi do a remarkably good job in providing high quality service, and we do it at the lowest cost of any other state hospital system in the country. Mississippi hospitals for years, decades, have been the lowest cost hospitals in the country. Our per diem expenses per patient per day are lower than any other state, and they have been for a long time. Our challenges in Mississippi don't have to do with high cost. They have to do with low reimbursement and low revenue. And the challenges are multifold, they're multidimensional. They cut across different payer mixes, but the challenges in Mississippi primarily derive from just the tough circumstances financially that our hospitals face. And that's not unique to rural hospitals. It's not unique to urban hospitals. It hits the same for everyone in many different ways. From the very beginning, Dr. Richard Field, for whom Field Health Systems was named, provided the comment on your left, but also talked about 3 factors that are necessary in hospital efficiency, and that's organized, competent staff, its accurate records, and its adequate diagnostic and therapeutic facilities. And that's what I think you see across the state as our hospitals work to provide quality health care to their communities. But he also believed in the value of reputation, and we do too. And where does your reputation come from? Well, in the hospital world, Dr. Field provided this quote as well, and it talks about the patient may not know anything whatsoever about the scientific details of their treatment, but they do know if they were given good meals, if the meals were properly served and hot and tasted good, if the room and the linens were clean, and if they were treated as a regular human being and not just a number. And I think, even though this quote was said back in the 1930s, it still rings true today. This is what I see as the core mission for our hospitals and really all of our healthcare providers. It's how we treat our patients, how we treat our family and friends when they come to our facilities, how they're made to feel welcome, and how they're made to feel special when they're there. And putting that above the bottom line sometimes is really where you need to be. And obviously revenue is important. Bottom line is important. If you're not able to sustain your operations, you're not able to serve your community. So you've got to be good stewards of those resources. But to me, this fundamentally captures why we're here, why we do what we do, and what our hospitals get up every day and try to live into. So the economic impact across the state, the numbers are down a little bit over the last few years as we've seen reductions in force in healthcare, particularly after COVID. We still haven't really bounced all the way back from that. These numbers are a couple of years old because we get new cost report data that we derive these reports from. But the impact of hospitals, the economic impact of hospitals across the state is pretty significant. The hospital industry pays almost $500 million in taxes to the Division of Medicaid to fund those supplemental payments that have been a lifeline for hospitals really for the last 30 years, but especially for the last couple of years since the Division of Medicaid enhanced the supplemental payment program that Medicaid provides to our hospitals that literally turned on a dime the profit margins of most hospitals across the state coming out of the pandemic as costs soared and revenue, kind of went up and down. Those payments have been a lifeline to support our large hospitals for sure, but also our small hospitals. Uncompensated care cost is still significant. And even though we've had fewer patients over the last few years fall into that category of uninsured, the cost for taking care of all patients has gone up substantially over the last few years. And just as we've seen in all of our everyday lives, the cost of living has gone up over the last few years, whether you go to the grocery store, the gas station, if you're building a new home, purchasing new products, the cost, the inflationary value has gone up tremendously. And for hospitals, the cost of labor has gone up tremendously, in addition to all the supply chain cost that they have to provide. Our hospitals serve almost 5 million people a year as outpatients, and the ED visits almost a little over 1.5 million per year. Obviously, a lot of the things that we focus on in MHA relate to advocacy, Medicaid, public health, insurance committees, workforce, and appropriations tend to be our main focus areas. And we're pleased to talk to you today about some of the implications as it relates to insurance. There have been a lot of successes regarding healthcare, regarding hospitals, and kind of that sweet spot is how it relates to payers, whether it's Medicaid or insurance providers over the last several years. I touched on the supplemental payments for Medicaid. The average commercial rate concept that was introduced a few years ago has been a lifeline for our hospitals, but for other hospitals across the country. There are some concerns on the horizon with that program that we'll talk to in a little bit, but that has been a massive benefit. And frankly, it represents more of a free market payment for hospitals than just a rate being set by Medicare or Medicaid. Crossover payments, the DRG base rates that were set to be eliminated it's about 10 years or so ago. That was an issue. Fought back on that, support from the legislature on that, many, many other things. And I'll conclude just the last bullet point being the most recent, prohibiting white bagging and brown bagging policies related to prescribed treatments. That certainly is a benefit for healthcare providers, for our physicians, and for our hospitals. but truly it's a benefit for the patients that benefit from those policies to where they know that they can get the drug that they need in the location and the setting that they need it from a trusted provider, and that it arrives on time, that there's a secure chain of custody for the product, and that when providers administer those physician administered drugs, that there's a confidence that the shipment has arrived in a secure and safe manner. So we appreciate the chairman's work on that as it worked its way through the insurance process last year. I want to talk about a little bit, some of the challenges that we have. And while I say challenges, there's also some opportunities here. Medicare Advantage plans have been getting a lot of attention over the last few years. And across the country, we've seen just a prolific growth in enrollment in Medicare Advantage plans. And oftentimes they are good plans for people. I don't want anyone to mishear me and say that they're all bad, because they are not. There are some patients that can go into a Medicare Advantage plan, and particularly if you're relatively healthy, then they may be the right choice for you. We encourage folks to talk to their providers, talk to their family members, study what their financial obligations may be, and before they make a decision. The enrollment period for Medicare Advantage will be coming up over the next few weeks, and we just encourage folks to look at that. But what we've seen across the country is significant enrollment. And in Mississippi, about 44% of the Medicare eligible population is now enrolled in Medicare Advantage plans. And that's a really high number. And there's some impacts of that on hospitals in particular. Rural hospitals rely on Medicare as their primary payer source. And frankly, urban hospitals do as well. But the total Medicaid revenues that are coming from Medicare are now split between the Medicare Advantage enrollees and the traditional Medicare enrollees. And as we've seen over the last few years, the Medicare Advantage enrollments climbed over the past 20 years. In 2007, it was about 19%. It's now up to over half from a national perspective. And then the Congressional Budget Office projects that to increase to 64% in roughly 10 years. So it's really incumbent that while we don't always have a lot of authority to regulate those plans, and Commissioner Cheney sitting here, and we've talked about this, and Bob, we've talked about this, we're limited from what states can do because the federal laws describe how the Medicare Advantage plans are regulated. Where we have been able to do some things, we have, and we've got great partners with the Insurance Commissioner's Office and with the legislature on doing some things. But, we've talked to our federal delegation about some things that need to be done, and I think that's getting some additional scrutiny there. Some of the challenges, and I've mentioned here in the last bullet, it's great to control cost. And I just said what a great job our hospitals do in controlling their own cost. And that's fine. That's a good way to do it. But what we don't want to do is have payers, particularly these MA plans, attempt to control costs by limiting the selection of providers, closing and locking in networks that may not be beneficial to communities that are being served, and then using tools like prior authorization in a more destructive and debilitating way. So for the impact on hospitals and patients, typically what you see is reimbursement that is well below cost. There are implications across the spectrum for all kinds of different things that are paid for. One of the biggest impacts has been on the 340B program, where the 340B reimbursement, or the drugs reimbursed that typically would be reimbursed for 340B programs, is much less, and they don't qualify for the same discounts and rebates if they're reimbursed by Medicare Advantage plan. And so that's been a big, I guess a stumbling block would be a kind way to put it, between patients, providers, and the 340B drug program. And it's really hurt a lot of our rural hospitals for sure, but even some of the larger hospitals have seen an impact on their bottom line from the 340B implications to Medicare Advantage. Diminished access to quality care, delays, denials, excessive prior authorization from the MA plans. Across the country, 81% of our rural clinicians report quality reductions due to some of these requirements. The Medicare Advantage patients typically face almost a 10% longer stay before a post-acute care is approved. So those patients stay in the hospitals longer before they're discharged and approved to go to post-acute care settings, which helps release some of the tension in the bigger hospitals that are trying to free up those beds for the severely acute patients. And then that just creates a backlog downstream. So trying to get that patient flow improved is something that's really important. And then just the delay and denial of the payments increases the challenges that our hospitals face, particularly here in Mississippi, where the margins are typically much smaller and the implications of cash flow becomes more tenuous. I want to commend the legislature last year for not passing legislation that had been introduced that would have allowed for some more relaxed solicitations over the telephone for some of the MA plans. To y'all's credit, once we flagged it and asked for folks to pull that back, y'all did it. So thank you for that. And again, there are instances where these MA plans can be helpful for patients. So I don't want anyone to leave here saying that MHA's position is just strictly opposed in all circumstances and there's not a gray area, because there is, and patients need to look at that. But we want people to go into these things with their eyes wide open. So you'll see more education from us over the next few weeks as we get into the enrollment season. Medicare Advantage is mostly regulated at a federal level, but there are some state solutions we think we can look at, and we'll be talking with y'all about that in the weeks and months ahead. Improving data collection, just for transparency purposes, is really important. And those reporting and transparency features can also lead into some of the education for our citizens who right now may not have all the information that they need to make the best decision for themselves. So we think there's some options there that can be easily achieved from a state perspective that won't run afoul of things that the federal government won't allow us to do. Streamlining prior authorizations. Y'all have done a great job. The prior authorization bill that y'all passed a couple of years ago is now being hailed as one of a model bill, which is a credit to Mississippi and the work that you guys have been doing here in the legislature and also with the insurance commissioner's office. So we appreciate all that. The challenge is some of those provisions aren't going to attach to the MA plans because of some of the federal requirements. So again, that's more of a federal issue to look at. So again, you'll see us as open enrollment season begins for MA plans and goes through December 7th. We'll have a more aggressive education campaign, awareness campaign to inform the public, inform our providers, and just make sure that people are making the best decisions for themselves. And with that, I'm going to hand this over to Leah Rupp-Smith, who many of you know and have had the pleasure of working with, as I've had the pleasure of working with for many years. And I've told several groups, Leah is in the position that I used to have with MHA, and I never knew how poorly I did my job until we brought Leah on. She has just been wonderful to work with, and I'm going to let her pick up here with the artificial intelligence.
Good morning. Thank y'all for giving us a few minutes today. And I'll be quick. I just have a couple of slides about artificial intelligence and kind of going off of what Richard was saying about balance. We have to strike a balance with artificial intelligence. I'm going to be talking about it from a billing and coding and prior authorization perspective, but the balance is between, patient protection and then efficiency and all of the things that AI can do. And I have a friend who said it best on her LinkedIn, and I told Richard I was going to tell you all today, but she has a little tagline on her LinkedIn that says something like, AI took my job, ... to the next level. So AI can be helpful. It can also cause some trouble. So this map just shows you what some of the activity going on with legislation related to AI and healthcare across the country. We've had 29 states pass some form of legislation related to AI. That could be related to prior authorization. It could be related to use of AI in practice. That kind of spans everything. And I think last year we had hundreds of pieces of AI legislation passed introduced across the country, including the task force that we passed, that the governor signed into law, that just got started touring some of our state assets recently. They're going to hold a meeting on September 25th, and then they'll have meetings in November and December. I talked to Senator Williams about that today, and one of their tasks is to look at AI in healthcare. And so we might be talking about some of these issues there too. Richard, you might have to help me with this. Oh, there we go. So I'm specifically talking about some billing and coding and prior authorization legislation. We've got several states that have passed legislation this year and more that are looking at it. Our prior authorization law, which is wonderful, and thank you for that, as Richard said, covers some of this. For example, a final determination has to be made by a physician or other licensed professional. There are other issues, for example, in the clinical review criteria that has to be flexible enough so that it can account for an individual patient's needs. So using AI to just automatically require prior authorization obviously would intersect with that law, but there may be some gaps. So this is just a slide to show you what's going on. Previously, AI and machine learning were really used for audits, for example, to flag fraud and things like that. Now, post-pandemic, they're increasingly being used to just automatically downcode or deny claims. And the reasons are obvious. It helps with cost containment for issuers. They're able to better compare peers. So they compare what one provider is doing to another. They assert that there are documentation gaps in medical records, and it's efficient, to use AI and just let an algorithm determine whether or not a claim is going to be approved. There are obviously big problems with that too, and that's what legislation is attempting to address. So every patient is individual, every patient has individual needs, and so AI oftentimes doesn't account for those needs in the medical records. So legislation that is being proposed attempts to address these issues, for example, requiring the review of an enrollee's medical needs to ensure that the tool isn't just basing a claims denial or a downcode based on algorithms or based on a subset that has already been determined, prohibiting the tool from basing its determinations solely on a group data set, requiring disclosures about the use and oversight of AI. So actually telling the patient that they're using AI and determining whether or not their claim is going to be downcoded or denied, requiring periodic review of the use and performance of AI, requiring a determination of the medical necessity to be made only by a licensed physician, which our prior authorization legislation dovetails into, and then requiring compliance with federal law, which they have to do anyway. There are several states that passed legislation related to this year. It may have some component of all of the components that were in the last slide. Maryland, Arizona, Nebraska, Texas, lots of states are looking at this issue, and I suspect there are more to come. So with that, I am going to kick the presentation back to Richard to tell you a little bit about the One Big Beautiful Bill and how it might impact insureds across the state.
So obviously, a lot of the bandwidth around healthcare over the last few months has been consumed with the One Big Beautiful Bill Act, HR 1. Depending on who you talk to, they may or may not use the word beautiful to describe the act. But be that as it may, I think what we're seeing this bill as is an opportunity. There's certainly some challenges in here. There's certainly some things I think are concerning from a hospital perspective regarding the state-directed payment program, which I talked about earlier, which has been a lifeline for our hospitals. We do expect in a few years, those payments are going to start to go down as a result of the legislation in this bill, where we're going to see that average commercial rate go away. It's going to be reset and capped at or ceiling, or however you want to look at it, at 110% of the Medicare rate. So we know there's a reduction there coming, probably to the tune of $100 to $150 million a year as we step this thing down in about 3 years when that begins. So we've got some challenges, but the way I've described it is also because we do have a little bit of a runway before those most critical pieces of the bill take effect, or the most damaging pieces of the bill take effect for Mississippi. You know, we know there's a hurricane out there, regarding this bill. We don't know exactly what the impact's going to be, what category it is when it's going to hit the shore, or where it's going to hit. So we've got time to prepare and board up and get ready, and also make the changes that we need to make from an infrastructure standpoint to be able to withstand some of those challenges. And I think that's really important for folks to hear, is that, while certainly there are a lot of concerns, so don't get me wrong, there's also some opportunities, particularly as it relates to the Rural Health Transformation Fund, which we spotlighted down here at the bottom. That fund's going to provide no less than $100 million to Mississippi. And it could be more than that, could be a lot more than that. We'll wait and see. CMS is still going through the process of issuing guidelines and regulations, and new things come out, or new articles come out almost every day at this point regarding what those funds can be used for, or what people believe they can be used for. So that's an opportunity to do some things for our rural hospitals, our rural healthcare providers, and make some adjustments and make some improvements on things that frankly they cannot do for themselves, because the margins traditionally have been so tight and the cash flow has been so tight in our rural areas that that it's just not possible for them to build a new hospital, reinvest in their community without a lot of extra help. When we talk about rural hospitals, it's important to know that, there are needs that the rural hospitals have that also implicate the larger hospitals as well. Our rural hospitals need larger hospitals to be able to transfer patients to when they can't take care of them in their local setting, either with in-person physicians and nurse practitioners and clinicians, or that they can't take care of through telemedicine. And those things are important. So it's important to have bed availability in our larger hospitals, but it's also important for our larger hospitals to be able to send them back when it's safe to do so for additional healing in their local communities. And we believe that our local hospitals deserve to be just as successful as our big hospitals. We believe our rural communities need healthcare in the same way that our urban communities do. And we believe that they deserve and have a chance to be just as successful as anywhere else. And so we're excited about the potential use that these funds provide us. We hope that, just as we did with Katrina, looking back now 20 years post Katrina, we see the difference in investments in infrastructure and things like that along the coast have made in bringing the coast back bigger and better, arguably, than it may have been prior to Katrina. We've got a chance to look back 20 years from now and not wonder what the hell we did with this money. And so I hope that we'll be smart and efficient in how we spend it, because it does present some opportunities there for us that we've not had and may not have again in a while. So some of the Rural Health Transformation Fund priorities: revenue, creating a state fund to cover the cost of uncompensated care, or provide a rural access payment to help these small hospitals as they go through transformational change, to pivot and shore up the potential loss of these state-directed payments that we know are coming down the road. And by the way, these are our priorities. These aren't, part of the one big beautiful bill. These are things that the bill can allow for. And these are the things that we have spoken to and spoken with our state folks who are putting together the application, what we've talked to them about. Investing in upgraded hospital facilities and equipment. I just had an opportunity to be in Hazelhurst on Monday as they're at their grand opening of a new medical clinic that's going to house pharmacy services, rehabilitative therapy services, multi-specialty physician clinics, and pain management clinics. That's what that community wanted. That's what they're getting. And it's all under one roof. So a patient can leave their physician's office, go right down the hall to their pharmacy, pick up their medicine, and then go home. But the excitement and the enthusiasm just around a new facility in Hazelhurst was amazing. At 9 o'clock on a Monday morning, you had hundreds of people there to get excited about what's coming to Hazelhurst in this new environment. Same thing, we go to Tippah County a few years ago, opened up a new hospital. Down at Field, opening up a new hospital. These new facilities make all the difference in the world in these communities, and they truly become a hub of community life. And those communities support those hospitals, and they support their medical communities in those ways. So we'd love to see some funds provided for that. workforce, creating a loan repayment program, shifting some of the focus and some of the resources away from the scholarship programs that oftentimes students decide after they've graduated, they don't want to stay and they renege on their commitments, and then it's hard to collect if we collect at all. And so looking at loan repayment programs to where maybe you get 20% of your loan paid after year one, another 20% after year two, and so on. That way the state's not putting all of its money out there at first and then hoping that someone lives into that commitment. So some opportunities there, we think, for use of these funds. Telehealth technology, wonderful presentation by UMMC today. They're doing some great things with telemedicine and telehealth that are making a difference across our state. Deploying those resources can be life-changing in many of our communities, but providing a stable stream of provider or payer payments for our providers who do that is going to be really important too. And they talked about the importance of payment parity. And so while we'd love to see some of these funds used for deploying these resources, we've got to make sure they're sustainable by providing that payment parity, because our clinicians are taking just as much time with the patient as they would in a brick and mortar setting. And so that's important to make sure that those funds are there to sustain it. And then just building on existing infrastructure. We've developed, at the request of the State Department of Health several years ago, a statewide HIE that captures data across the spectrum of whether it's a hospital or a clinic setting, and connecting payers to that HIE so that we have better insights into what the patients are doing, where they're going for their services, what the cost of care is, and it facilitates better communication between payers and providers for improving healthcare outcomes and doing it at a lower cost. So taking that to the next level with additional care management features and bed availability functions to continue to improve the healthcare outcomes and continue to reduce the spending, we think is also really important. And then finally, as we move away from the One Big Beautiful Bill Act and into this fall season before Congress goes home, and still some work to do on the healthcare front and extending, delaying the Medicaid disproportionate share hospital payment reductions that were part of the Affordable Care Act that have been kicked down the road every year for the last several years will be crucial in maintaining a stable hospital environment. But then the biggest one is really the last one, and that's appropriating funds for the federal exchange subsidies. And so we wanted to make sure we highlighted all the things that the One Big Beautiful Bill did, but also the things that it didn't do. And one of the biggest things that it didn't do was extend the federal exchange subsidies that have benefited patients and providers, and frankly, stabilized the insurance marketplace in Mississippi. We've seen hundreds of thousands of new enrollees in those Affordable Care Act marketplace exchange plans over the last few years. Coming out of COVID, there were funds appropriated by Congress, and the cost sharing provisions of those plans were provided for, and it's made all the difference in the world. I'll tell you, our hospitals for a long time hated those things, hated those plans because the deductibles were so high, the patients couldn't afford the deductibles, the hospitals couldn't get paid. And they also couldn't count them as uncompensated. Well, they could count them as uncompensated care. They wouldn't be able to count them as uninsured for the purposes of some of the federal payments that they can get for taking care of uninsureds. But since the cost sharing has been picked up through these exchange subsidies, we've seen not only a decrease in the number of uninsureds in our state, but also the ability to get the care that they need and not file for medical bankruptcy having to do it. And the providers, the hospitals in our case, have been able to get paid for those services, and the patients have been able to avoid devastating bills and get the care that they need. So we're hopeful that those will happen, but we wanted to flag that for this committee's attention, because without continuation of those exchange subsidies, we do think there'll be a loss of tens, perhaps hundreds of thousands enrollees in these marketplace plans, which will be extremely disappointing for those patients, but also really devastating for both the marketplace industries as well as our providers, and particularly for the hospitals. So wanted to flag that just for your awareness on that. And I know many of you have already had conversations about it. And I'll be glad to stop and try to answer any questions. And if they're really hard, I'll pull Leah up here.
Yeah, please get a microphone so the people on Zoom can hear you. Thank you.
Thank you, Mr. Chairman. So I'd like to follow up on one thing Richard said. The Mississippi Department of Insurance is very concerned about the advanced tax credits not being extended by Congress. We are already seeing on our filings up to 40% rate increases on average. We anticipate hundreds of thousands of people to be dumped back in the uninsured market as a result of this. And there's a trickle down, of course, from this. We're afraid it's going to impact the hospitals and other providers. So just wanted to share that. And then Richard, real quick, tell us approximately how much the hospitals received in state directed payments last year and what those funds were used for.
Yeah, so, overall, the program has grown to about $1.5 billion. A few years ago, it was around 500 million. With the increases and the changes that were put in place in 2023, it grew. The net effect was a lift of about $750 million at that time over the total supplemental payments. When you wash that out with what hospitals were paying and a provider tax to get that, frankly, that flipped the bottom line. It flipped the operational cost on its head for many hospitals, including some of our big hospitals went from a few $1 million or tens of millions of dollars in the hole, or having to look at reductions in force, laying off staff, discontinuing services. It allowed them to continue to provide services. So the impact has been enormous, primarily keeping the doors open. We have had hospitals that, because of that program, before the potential changes in the legislation from Washington, where it looks like we're going to start eliminating some of those funds or stepping them down over time, we had some hospitals who had given up on services such as labor and delivery, who actually were starting to think about bringing them back up. Now they've got the concern, well, if I bring them back up again, am I going to be able to sustain them? So those conversations are going to evolve. A lot of it depends on the wild card of how these rural health funds may be used. The implication of that, combined with the step down in 2028, 2029 of these state directed payments. But it's been a lifesaver to sustain. I mean, it has paid for staff, it's paid for service continuation. And in some cases, hospitals have looked at bringing back service lines that they discontinued because they couldn't afford them. Medicaid became the best, if not the best payer for hospitals because of those payments.
And just one follow-up question. If you were to lose half of that, what do you foresee?
Yeah, well, so I just point out the uncompensated care costs have gone up in spite of the fact that the number of insureds has gone down. So, $600 million uncompensated care cost, if the net pickup of those state directed payments in 23 was about $750 million. Well, now you're 150 million to the good if you compare uncompensated care to the pickup over there. As those things as the state directed payments start to tailor off in a few years, 100 million a year, let's say, goes away each year. You're now breaking even across the state, and obviously some do better, some do worse. Hospitals. The concern is, just as you pointed out, if we start losing more members on those exchange plans, then the uninsured numbers go up. The cost of care the uncompensated cost of care is going to go up too. And we could be looking at some really, really devastating problems, not just for small rural hospitals. It's for the big ones too, because a lot of the big hospitals, from an operating margin standpoint, were made whole and then made a profit because of those state directed payments in 2023, 2024.
Thank you, Richard. Thank you, Mr. Chairman.
All right, Dr. Bryan.
I had a follow-up to Leah's comments on AI, which you guys know I have a particular interest in. And I like to zoom out and look at the big picture sometimes to kind of, as I understand it, what's happening with some of this money. And as the legislature looks ahead, what we can do with it. From my perspective, as tech rolled out new advances about what they could do in medicine, we can do this bell and whistle and this bell and whistle. There's a lot of things that I say really got ahead of its time in the medical records. And there are not that many medical record systems in the country. And some of them are even being looked at for monopoly type effects and so on. So these are large corporations that want various clinics or hospital systems to use their services. And so the more that they can generate AI or algorithmic information that draws revenue or complex diagnoses or plans into the awareness of the clinician, there's a risk there that the person at the bedside may think this is accurate information when maybe it's not very accurate at all, because none of these things are 100% accurate. It's just not possible. So we know that AI, even in medicine, is not perfect. So we began to see that there's risks popping up that as a physician, I want to know that where did this information come from, that's being suggested to me. And so the concern that we're seeing is that people are believing things naively a lot of times. There are bad actors in the world, but it's like, this must be accurate information. It gets mixed up into claims, and it's a small percentage of the time, but across the country, it does add up into some coding that is AI prompted or AI entered into a record. So you really can't blame, in my opinion, the payers completely, saying, we've got to figure out a way to get ahead of this too. We're going to use AI and drill these things down and figure out where we can get some clawbacks, because we don't want to pay for something that didn't happen. And then as the doctor, I don't want to be at risk for fraud either, right? I want to submit the care that I did. So we're seeing this battle of the AIs on either side. And I think the human in the loop technology is really important, making sure that whatever we craft down the road here in our state, that we understand companies wanting to make sure they are paying for services that are rendered, but don't get too far over your skis with AI tools. Make sure there is a competent human that is overseeing how you augment your business practices. And on the side of the clinical care, we want to make sure too that our doctors and our other clinicians are being presented and protected accurate information that's augmenting their practices and not putting them at risk and not asking for more than they're due. So I think it's just, from my perspective, we're in the middle of this growth curve. And I know the task force is looking at it, and you brought some points up, but to me, that's the big picture. Is everybody's trying to figure out how to be safest and more efficient, and we're not there yet. Thank you.
That's a great
Sounds
point.
like AI and medicine is a subject we can study a bit more in the next few months. I'm going to ask that we move on because we're trying to get out of here before noon. We thank you so much, Richard and Leah, for your wonderful presentation. Thank you for being with us this morning.
Thank you very much.
Thank you. Last month, Dr. Bryan, not Senator Bryan, but Dr. Bryan was discussing an issue that it was brought before the committee that said that's an interesting subject. We'd like to hear more about that. And that's the subject of medical bus or Medicaid buses in rural areas in Mississippi. So Dr. Bryan is going to introduce a couple of guests that are with us, and we have about 10 to 15 minutes for this presentation, please.
That's right. Thank you for the indulgence of the committee. And we have been tickled at the name Medicaid bus, which is the nickname we've given this, and thank our friends at the Molina Healthcare of Mississippi. I do want to say that I've spoken to the administration at all three cans since we last met. TrueCare, Magnolia, and Molina, and everybody has an interest in the feasibility of this and are supportive in general concept. So thank you. We have with us today David Livingston, who's the plan president of Molina Healthcare of Mississippi, and Tara Clark, who is the associate vice president of state government affairs for Molina Healthcare. And they're here to talk to us about the high level concept and some of the discussions that we've been having over the past year about what this might look like to help augment getting care into more rural areas. Thank you for being here.
Absolutely. So thank you, Dr. Bryan. Thank you, Mr. Chairman and members of this committee for allowing us to appear before you today to talk about rural health strategy and innovation, which we all know is critically important to folks here in Mississippi and the people in this room. So as they said, my name is Tara Clark and I represent Molina Healthcare. And prior to my career in the private sector, I worked at the Division of Medicaid for many years. I have known many of you on this committee and worked on a lot of Medicaid issues over the years. I'm a lifelong Mississippian, grew up in Rankin County and have lived in Madison for 20 years or so now. So I'm very proud to bring that local perspective to the work that we do here every day. So Molina is honored to serve Mississippians through our Medicaid and Marketplace programs since 2017. And we share your commitment to strengthening access to care across the state of Mississippi. And so as many of you know, our Mississippi rural communities face unique health challenges, and Our residents have to drive long distances just to get basic care. We know that our rural hospitals are experiencing significant financial strain, and preventative care in our rural setting often comes too late or just maybe doesn't come at all sometimes. And so we know these access gaps certainly lead to higher costs. They lead to avoidable emergency room visits and poor health outcomes for our residents across the state. And so at Molina, our strategy is pretty simple. We are focused on meeting people where they are. And one way that we have been doing this now for several years is through it's a Medicaid bus on the agenda, but it's our rural, it's our mobile clinic and our pop-up clinic. So it's a big state-of-the-art RV and our pop-up clinics that we have throughout the state of Mississippi. And these clinics are bringing primary care, preventative care, and behavioral health services to our rural communities throughout the state. So as you can imagine, that's reducing barriers such as transportation, workforce shortages, as we've heard, and affordability. So I want to introduce you to our new plan president here for Molina Healthcare of Mississippi. This is David Livingston, and he comes to us by way of South Carolina. And he has been with us since the end of May, I believe. And one of his first duties was attending the Mississippi Association of Health Plans Conference the first week of June. And our friend, the commissioner, Mike Cheney, gave him a big Mississippi welcome by asking him to serve on a Mississippi Medicaid panel with about 2 minutes prior notice. And he had been on the job about 10 days. So I told him, we joked, if he can survive that, things can only go up from here. And so I'm going to let him talk to you a little bit about our rural healthcare strategy, our innovation, and all the unique things that we are bringing to our rural communities throughout Mississippi. And then we'll be available for any questions as well.
Thank you, Tara. Thank you, Mr. Chairman and member of the committee. I'm David Livingston. As Tara said, I'm the plan president for Molina Healthcare. Today is actually my 4-month anniversary. But I am proud to be here. Have my driver's license, have my house. We are just so happy to be in Mississippi, thrilled to be here. Although I've only been in Mississippi a few months, I've been running Medicaid health plans throughout the country for about the last 16 years. I spent my entire career in managed care. So I'm just really excited to be here to serve the state. I guess I'll just make a couple quick promises before I get started. One is I know there's a time limit. David Livingston never goes over time limits. Number two, I learned about the Medicaid bus when I saw the agenda, so I don't have a bus to bring you today. And three, I'm not going to ask for anything today. So I really just want to be able to share some of the great work that the Molina team is doing in partnership with providers throughout the state. And, what I'm talking about is Molina, but I know that all of the MCOs are doing great work, focusing on rural health strategies. We're all doing it a little bit different. And I think that's why we have 3 different MCOs. So we're all addressing different issues of the challenges of access in the state of Mississippi. My handouts aren't really great, but I'll kind of talk about it. So there's a picture of our mobile clinic as well as one of our pop-up clinics. So we have an RV that is available to go anywhere in the state. We started this in July of 2022. And over the last few years, we have had over 500 clinic days between our mobile pop-up clinics and our RV. These are fully equipped with 2 patient offices, and we partner with provider groups to do visits. Really, it's about, as we've analyzed it and studied it, we know that there are access issues. We are in no way trying to take the place of providers. We don't deliver the care. We partner with providers and markets, but we provide the access. We'll come where the patients are, as Tara said. This mobile unit, again, we drive it all over the state. And another thing that we can do with this is when there are state emergencies, natural disasters, we will show up at the site to assist those providers on their sites. We've done this in tornadoes in the past, hurricanes. We'll come out to that market and provide support, and we fully staff this. These pop-up health centers, we have 3 of them. They're best described as basically kind of like a trailer. Typically, we will, we want to find areas that we can utilize them fully for at least 6 months. We currently have them located in the Greenville area, Biloxi, and soon to be in Tunica. And I hope I'm pronouncing those right. That's one thing that I've learned as I've moved from state to state. I've got to learn to say the cities correctly. So I apologize for my funny accent. But, you know, if there is demand, that if there is an area where we believe, you know, providers and the MCOs and the state say, you know what, we need access in this area. Because one of the things that's really important about our mobile strategy is we don't just serve Molina members. We serve the patients that the physicians serve. And so there is no discrimination against you, only a Molina member could show up. My vision, my dream is that every one of these units that we have over 200 clinic days a year in each of these. And I believe there is enough demand in this state for that. And we want to be a partner and bring that solution to the state of Mississippi. So, you know, we're always open to conversations. So some of the services that are available are listed on here. It's really kind of like primary care light, but we also have telehealth facilities or telehealth capabilities in that. So if there is a patient, a member who is in a rural area and needs to meet with a psychiatrist who is only available via telehealth, we can arrange for an appointment for them to come in a clean, safe, private room to have that telehealth visit if they don't have that access at home. We do wellness exams. We also do a lot of health education. We provide that. We staff for that. The providers don't have to staff for that. We provide that. We partner with a lot of community agencies. Over the last 2.5 years, we partnered with over 75 different community agencies and put together health fairs in conjunction with this. So it's a really cool thing. You know, and we're in discussions right now about maybe doing a pilot, which I think is really exciting, where we identify, where Molina would identify and join, you know, with Dr. Bryan and find maybe 30 to 50 of our members or patients who are really have certain chronic conditions or have certain socio issues that, you know, make it difficult for them to get the office. We'd partner with she and her practices, and we would arrange for transportation. We'd assign care managers, case managers, you know, case buddies to work with those patients, help them get to those visits, you know, figure out how we can extend telehealth. And we really want to measure that over time to see the efficacy, to see if this is a care management program that can really move the needle for some of the most chronic patients in the state of Mississippi. You know, what I really want to emphasize on this is, you know, our statewide reach. We will be anywhere that RV, we have a driver who's a full-time driver, and we can show up and staff that anywhere in the state. I think the other thing that we really want to emphasize is, you know, as long as the practitioner, the provider is a contracted provider, we'll work with them. If they only see 3 Molina members and 40 other members in a week that are not, that's fine with us. We want these used. You know, we made a deliberate decision in 2022 that we wanted to reinvest in the community that we serve. And so that's part of our overall corporate philosophy is we want to reinvest in the communities we serve. And this is part of our corporate reinvestment strategy. And I would love to see this grow, but we got to fill it first, right? So if we can fill them, we can bring more to the state. And again, we are not competing. We are just providing space and tools for the practice. You know, from the provider, we are not in the delivery of care as a health plan, but we will facilitate, we'll provide support. So the providers need to provide, you know, physicians, nurse practitioners, nurses, medical assistants, and need to be obviously Medicaid certified, although you could also see non-Medicaid patients. Yes, I'll skip ahead. Interest of time. So we do provide support for this, again, non-clinical, but for our Molina members. So if we know that there are 20 Molina members that where the RV is going to be showing up on the second and fourth Thursday in a certain market, we will, work with the physician who's going to staff that, identify common patients, and we will outreach and we will coordinate those appointments for our members. Not only will we make sure they have appointments, we will arrange for transportation. We're going to call them 3 days before, and we're going to call them the day before. And probably the morning of, to make sure that they are going to show up, because we do know that, there is a certain degree of any patient who's a no-show, but Medicaid has a higher propensity towards that. And a lot of that has to do with transportation issues, and they also have a lot of other distractions in their life. And so we have someone hand-holding to make sure that they show up. We provide a basic stock of medical supplies and equipment. So the bandages, the syringes, all the stuff I don't know a lot about. But those medical supplies, we make sure that they're there. We're there to clean and prepare the unit. Basically, we are the back office administrative staff for that. We'll provide registration. And then we often do like to coordinate and have health fairs if possible, but we know that won't happen every day. And then we'll also work with those practicing physicians and nurse practitioners, nurses, to identify a list of Molina members who have gaps in care, right? So if there is someone who needs to have their blood pressure under control, but they have not been monitoring this, we'll make sure that we notify that physician that David Livingston's coming in, he has high blood pressure, he hasn't had his blood pressure checked in 6 months or 2 years. Make sure we get this done. You can do A1C testing. There's all sorts of things that we can do to collaborate. So, we are really thrilled and excited to be part of this, to be part of the solution. And again, all the MCOs are doing great work. This is something that we're doing. We're very excited to work with any willing provider who wants to do something. Our goal again is to have, right now we have capacity. We know there's more demand than we have capacity. So we're really trying to work together to make sure that we can bring everyone together and make sure that Mississippians get that care that they deserve, and that we can bring it to where they are. And so that, our provider partners don't have to build facilities in some of these rural departments. If we can be reliably that partner that shows up on the first and third Wednesday in a particular community. So that really kind of concludes my comments. Thank you, Mr. Chair. Thank you, member of the committee, for allowing me to talk. And I will stand for questions.
Thank you guys for coming and presenting. I appreciate it very much. And we look forward to continuing, the physicians do, on how we can meet the needs of the state. Thank you.
Thank you. Thank you for inviting me.
Thank you, Mr. Livingston. We appreciate you, Ms. Clark.
Thank you.
Okay, our last item today refers to legislation that we passed a couple of years ago. It was a legislation that Representative Creekmore authored, and the members of the insurance committee decided to put a repealer in it just to make sure it didn't have any cost effects on or what the cost effects were on our state health plan. So I want to yield to Representative Creekmore to describe House Bill 1143 and where we stand on that, please.
I always joke with Senator Bryan, I send a good bill over to the Senate and they always change it. And I send another good bill over and the insurance committee changes it. So I can always count on that. But House Bill 1143 prohibits insurance companies from using step therapy or fail first protocols for cancer patients with stage 4 or metastatic cancer. And so it gives the patient the chance to go and receive the most effective medicine available, and the insurance companies pay for it. And just on a personal note, as my office manager back in New Albany just last week, her father was having back issues, goes to the doctor, finds out he's got stage 4 cancer in his back. So I was doing the research on this to get reacquainted with this bill, and actually printed it out and gave it to the family. So just be sure the insurance companies know. So I know from a healthcare perspective, it's being effective in our patients in Mississippi. So that's an explanation of the bill.
Initial response for our committee member who represents the Department of Finance is that it's had negligible effects on the costs of the state plan. Commissioner Cheney serves on the oversight on the board of the State and School Employees Health Insurance Board. And would you please chime in on the bill?
I will tell you that what it does, it saves lives. Think about it. Because you avoid stealth therapy, you give that person at least another year of life. Stealth therapy can cause year delay in treating cancer. Gotta have an aggressive treatment. So,
Thank you.
question, Chairman?
Any questions on that legislation? That's one of the goals of this committee, is to look at legislation we passed. And since this has a repealer in it, we'll be addressing that this next session. Anything else that any members of the committee? There's Brian.
Mr. Chairman, I was just going to comment briefly on something that came to me as I was mulling over the presentation. I think we need to think, I think we know this, but we don't always realize it, what it means to be in a hospital or in a nursing home in the town where you and your family live. It means your family members and friends can stop by to see you on their lunch break, after work. And the interaction with your family and your friends makes a big difference. I think we all realize the difficulties that came about during COVID, when people who were in hospitals just couldn't have that interaction because it wasn't safe, and the impact that had. And I think that we need to keep in mind the critical need to have healthcare facilities, in fact, available in small towns and rural areas. That's not going to happen just organically. It requires planning and intentional action on the part of us here in the legislature and in the various agencies. And I would hope that we would keep that in mind as we go forward. Dr. Field would agree.
Dr. Underwood, you've been mighty quiet. Anything you'd like to mention today? We're hoping next month that you've got some, you filled out your form very well for us, I want to say, with about 5 or 6 subjects. So we're going to put you in charge of a couple of those next month.
I rarely suffer from a lack of things to say. It's having, hopefully learning the wisdom of listening a little more. Nothing specific. Again, I look forward to a lot of the concerns I heard today are shared concerns. Yeah, I think that probably goes without saying. A lot of the challenges we face in terms of taking care of our patients. I was thinking, as you just now spoke, for let's see, when I came back from my training, born and raised here, trained away, and came back in 2001 to, of course, zero practice. And as a lot of new providers was trying to decide how to build a practice, my father is from Scott County in Forest, Sebastopol. And so I went to Lackey Hospital just up the road. My grandparents lived 6 houses down, and I would have breakfast with them on Tuesday mornings and then walk up the road and do maybe 2 colonoscopies, and was glad to be able to do that. And my grandparents have long since passed, but 23 years later, I'm still there every Tuesday, and now seeing 15, 20 patients a day. And the point being, meeting people where they are is important, and people being able to be seen not that it's too far for a major, problem to come to Jackson. Oftentimes that's necessary, but to be able to find ways to extend care, whether it be by telehealth, or by driving, or by having, or being driven in a bus or what have you. These are all just really important things in a state that has unique needs, the rural aspect, the socioeconomic challenges that we're all familiar with. So anyway, I look forward to working with everybody, all the different players, the important players on the payer side, on the provider side, and certainly the patients to try to fix what can be fixed.
Great, thank you so much. On that, want to remind you, members of the committee, please fill out the forms. We're going to have several more meetings. Attendees today, if you have a subject you think is important for us to discuss, please mention it to one of our committee members. We don't have an agenda. We want to cover anything that's important to healthcare in Mississippi, and that's the goal of this committee as it was set up. Thank you for being here today. Our next meeting will be 4 weeks away, October 9th, in the same room at 10 a.m. We'll see you then.